From the campus of the University of Kentucky, this is Behind the Blue. I'm Cody Kaiser with UK Strategic Communications.
In palliative care, we often talk about pillow messages. So there's this artist, Nathan Gray, who's at Hopkins, and he also is a medical artist. He does cartoons and comics and is fabulous. And he drew these pillows that have these sort of toxic positivity phrases that people like to say to people who are going through hard things, like just hang in there, be positive, it gets better, thoughts and prayers. And as genuine as it may be that those things come across, they are often with a subtle, maybe hidden intent to fix/avoid really how difficult that moment is.
That's Dr. Abbie Latimer, an assistant professor in the University of Kentucky College of Social Work, with an affiliate appointment in the UK College of Medicine's Division of Palliative and Supportive Care. Before joining the faculty, Latimer worked as a palliative care social worker with UK Healthcare, helping build the inpatient palliative care team and supporting patients, families, and care teams through some of life's most difficult moments. Her work now focuses on research and teaching around serious illness, moral distress, communication, and the way clinicians, and all of us, can better show up for people who are suffering. Latimer recently spoke at TEDxUKY, where she shared the story of a patient she called Fred and explored questions many of us have faced. When someone we care about is going through something painful, what do we say? Why do we sometimes pull away? And how do we find our way back to simply being present? On this episode of Behind the Blue, Latimer joins me to talk about hospice and palliative care, why well-meaning phrases can sometimes create distance, and how asking better questions, listening without an agenda, and simply being present can help us support one another with more compassion. Abbie Latimer, thank you so much for taking the time to sit down and talk with us on Behind the Blue.
Thank you for having me. I'm excited.
So the first thing I want to ask is for you to kind of give a little bit of background as to, for people who are meeting you for the first time. Give me a little bit of your title, your role, and then here at UK, and then I want to kind of jump into kind of what your day-to-day looks like with the university.
So I'm an assistant professor with the College of Social Work. I'm also appointed with an affiliate position with the College of Medicine and the Department of Internal Medicine and Division of Palliative and Supportive Care. And I am predominantly doing a lot of research right now, but I'm also developing a course in psychosocial care for social workers and hopefully other students as the course launches in the fall for the first time. I came from UK Healthcare as a palliative social worker. We started the inpatient palliative team, myself and several other team members. And now there's 3 social workers and an outpatient team. So it's grown quite a bit. It's gone from a team of 5 people to, I think, 15 or 17 people. And got my PhD while I was working there full time and started over here started at the College of Nursing, actually, and then transitioned over to the College of Social Work. But I am an all UK born and bred. Undergrad, grad school, PhD, job, and now I'm here.
Okay.
Yeah.
What drew you to this particular field? Like, what was it? Was there something as a growing up as a child or in high school or something in college that made you want to go in this direction?
I wanted to be somebody who helps somebody. I think that's the typical response of somebody that goes into social work. But I started in psychology. I found personalities and human behavior to be really fascinating. And when I was a psychology major, I learned that there wasn't a lot you could do with just a psychology bachelor's degree. So I went on to a master's in social work and learned about what the social work field was and how having a degree in social work takes you out of just the clinic setting and allows you to really understand the person in front of you and what they're dealing with aside from what they bring to you in the room, and learn how to advocate for them and help them outside of just psychotherapy. So while I was in the social work program, you have to do these residencies or practicums where you work for free for different agencies. And I got assigned to the Alzheimer's Association. And while I was there, I was noticed to be particularly good with the individuals who were in advanced stage dementia. And so they said, had you ever heard about hospice care? And I said, no, I hadn't really. And so they signed me with hospice care, and that's where it all kind of started. So I started the first freestanding hospice facility in Eastern Kentucky with, it's Bluegrass Care Navigators now. It was Hospice of the Bluegrass then, and worked in Hazard, Kentucky for a few years, and then transitioned back up to Central Kentucky, and then did some outpatient community mental health, and then over to UK Healthcare, where I started the Palliative program.
You mentioned, wanting to go into social work or wanting to help people. Mm-hmm. Was there some catalyst early on in your life that kind of pulled you towards that?
Gosh, I wish I had more of a compelling story. I liked Frasier a lot, the show Frasier.
Sure.
I was a kid who watched all my parents' shows, and I really liked that he had this big black chair that he sat in, and I like this idea of a psychiatrist and a psychotherapist. So I liked the idea of it a lot. Hospice got more personal. My grandmother was in hospice, and I didn't know what hospice was at that time, but I was really close to her. And at that time when she had it, I just remember our time with her being so precious and so protected. So I really appreciated that about it. And I thought, well, if I could do that for other people, that would be nice too. So I just kind of got the best of both worlds through my early career. And I think all of that clinical work, I don't think I know, all that clinical work really motivates and keeps me grounded in my research now that I'm way less clinical than I used to be.
I think it's interesting. A lot of people, I'm sure people are aware of this and know, but there are probably a lot of people who don't. Just the broad range of areas that social work touches on. You're not a caseworker for necessarily, you have those, the caseworkers that work with families, work with kids, who work in those types of settings, with like family welfare, things like that. People who work in offices behind desks, but then you also have the people in those clinical settings, like with hospice and palliative care, and just a broad range of healthcare areas that social workers are necessary for in order to help people along. When people hear hospice, I think that's a term that a lot of people are familiar with. Mm-hmm. They kind of have an idea of what that means. But I think a fewer amount of people probably know palliative care. Mm-hmm. So in plain terms, what is palliative care and when does that come into someone's life? And is it linked with hospice in a way where like you can't have one without the other or vice versa? Or are they independent in a sense?
Square rectangle type deal. That's a really good question. And I think going to your point about social workers being everywhere, they are everywhere. Social workers are everywhere. I know that is something that the College of Social Work here prides themselves on, is understanding that social work is everywhere, literally. But regarding palliative and hospice care, so hospice care is for anybody with a terminal diagnosis of 6 months or less, and that's pretty heavily regulated by Medicare in terms of benefits and how it's reimbursed. And so that 6 month is something that they have to hold to. So if they anticipate you to live longer, then you can graduate hospice and leave hospice and discharged alive, is what they say. Palliative care, though, is less regulated. Therefore, it's really for anybody with a serious or life-threatening illness of any stage, of any age. With hospice care, it's kind of divided into pediatrics and adults. Pediatrics are more likely to have what they call concurrent care, or care that's received at the same time as curative measures. They can also receive hospice, but they don't let adults have that same type of level of care, even though that's really what would be the best. It's, limitations in our system. But palliative care is that extra layer of support for anybody with a life-threatening illness that's intended to alleviate the symptoms that come along with a life-threatening illness, nausea, pain, vomiting. But it also addresses the spiritual and the psychosocial aspects of going through something like that. So that is where social work comes in. And social work can look really different depending on where you receive palliative care. So unlike hospice care that has specific mandates around the different settings, palliative care is often delivered in all sorts of different settings. So sliding fee scales are a common option to pay for it. So they can receive it at home, in outpatient clinics like we have here at Marquis now, inpatient and hospital settings. There's also inpatient wards or floors designated. We have a floor designated for inpatient hospice at Good Sam, but other units, we don't have one of these at UK, but other hospitals around the country have inpatient palliative units where people actually go and stay inpatient, but they're not hospice, they're actually palliative. So it's really it's really versatile in how it can be delivered and what that looks like. And the team structure can look really different. Some teams are a nurse practitioner and a social worker. Some teams are a doctor and a pharmacist. The ideal composition is all of the above: doctor, nurse practitioner, nurse, social worker, pharmacist, chaplain. Teams have been starting to expand to include death doulas and other types of mindfulness care-oriented professionals as well. So
I think it's fascinating how a lot of this stuff is designed to kind of work seamlessly and also almost in some ways kind of invisibly, like behind the scenes of things. And one of the things that really stood out to me was this idea that, and I've had some familiarity with both hospice and palliative care with family members, but that it's when you're working with professionals in this area, they are working with not only the patient, but that patient's immediate family and friends in ways that I think are not often spotlighted and should be spotlighted because of the importance there. Tell me a little bit of kind of about that kind of relationship there with working with families in a sense.
Yeah, it's I sort of think of it like a care system. So some people have people in their care systems that they identify as family and friends. Some people don't. They have people that they trust and that they're close to, but wouldn't necessarily call them friends or family. So what I appreciate about palliative care is the inclusion of language to be more inclusive for people who maybe don't have traditional type relationships. And so I work a lot with individuals who are homeless. And so often the people that know them the best are their case managers at their shelter or the case managers at their permanent supportive housing site. So in working with the care system, in palliative care specifically, it's helpful to anybody that's in that room. If you're in an inpatient setting or outpatient setting, anybody that's brought in and or referenced could be a person you might need to work with to think about how to help this person or support this person, to the extent that it also includes other professionals too. So not just with case managers at shelter settings, but a lot of the relationships that I cultivated were other consultants within the hospital. So worked really closely with the advanced heart failure team, which is sort of how I shaped my research agenda. But we worked really closely with people who would consult us for help. And so people don't think about how much emotional attunement other clinicians have with their patients. But as a palliative clinician, it's the patient's family, people that are close to them, and then it's all the other providers that are also taking care of that patient. They're also delivering news and they're delivering treatments that are hard and difficult. So it wouldn't be a typical day would include not only counseling the patient, but likely counseling their sister or their friend in the hallway, but then stopping alongside of the staff room or the nursing room and counseling the nurse that's taking care of them. Because everybody has a unique and individual relationship with that person. And that's really where all my moral distress research also got started, was most of the time, the most distress happened to be coming from either a family member or person in the room or one of the professionals taking care of them. Yeah.
Interesting.
Yes.
So I want to kind of jump into this. You recently took part in an event that was tied in with TED Talks. It was TEDx UKY, which featured a lot of UK speakers, and you gave a presentation. It was about a particular, the core of it was about a particular patient who you named Fred. Mm-hmm. And it kind of delved into this idea of the problem of kind of the what do I say problem.
Yes.
And you mentioned people ask you all the time, how do I talk to someone who's going through something hard, who's going through this kind of situation? And that could be family members, that could be care providers, doctors, nurses, counselors. Just in a broad sense, why is that so difficult for us, even when or especially when we care?
Yeah. Emotions, right? Emotions are hard. Difficult things are hard. Difficult feelings are difficult. And that's the easiest way to put it. Death is scary. It's never going to not be scary for most people. And so when we care, we usually have more emotion. And sometimes our immediate response is to avoid because that emotion can be really intense. And the emotion kind of bleeds over into that person too. You don't want to upset them. You don't want to make it worse for them. You are thinking about them, but because it causes so much emotional distress without good engagement and empathy and good regulation, sometimes that just kind of spills over and we're processing conversations with really unchecked, unregulated emotional distress. And that's when the focus is now no longer that person in front of us, but it's sort of what's happening with us and how difficult this is for us. And it's never to insinuate that anybody is selfish when they're talking with somebody else. It actually is very much the opposite. It is because they care so much and they want to say the right thing. But some of that desire to say the right thing comes from this place of wanting to fix it for them. And it's not that you don't want them to feel what they feel, but because what they're feeling is difficult for you and you want to lessen your own distress, by virtue, you're also then kind of stifling their emotional response as well. And it's a unfortunate byproduct of just not being aware of how we're coming across and or how we're feeling and trying to stuff that feeling versus just letting it live and exist and acknowledge it. And sometimes silence is the best option.
Yeah, I was going to ask what people usually want to accomplish in those moments, if it's comfort or hope or fixing the pain some way or not making it worse. And it seems like it's often just a good mix of all of those things.
Yes, all of the above. And that makes it hard too, because I think if we could pinpoint what it was that we wanted to do, it might be a little bit easier. We can always think of some type of phrase that might offer hope or compassion. But sometimes those come out more as sort of toxically positive, sort of the silver lining of illnesses. I think Brene Brown talks a little bit about that. But in palliative care, we often talk about pillow messages. So there's this artist, Nathan Gray, who's at Hopkins, and he also is a medical artist. He does cartoons and comics and is fabulous. And he drew these pillows that have these sort of toxic positivity phrases that people like to say to people who are going through hard things, like just hang in there, be positive, it gets better.
Thoughts and prayers. And as genuine as it may be that those things come across, they are often with a subtle, maybe hidden intent to fix / avoid really how difficult that moment is. Yeah. So you open your talk with this patient who you call Fred. And just for people who are listening who may not have heard this, what was it about that first meeting that really stayed with you?
I think what stayed with me with Fred was how nonchalant and matter of fact he was. And his lack of distress actually made me not all that distressed either, in the sense of, well, he doesn't seem to be too bothered. And, I'm very much a promoter of agents of self. And if it's not distressing to you, then I'm not going to make it distressing for you. But I think it was maybe efforts in both of us to avoid how bad this could potentially be. I think him being homeless was particularly challenging, not just from a logistical standpoint of how are we going to get you to appointments, and what does this look like, but he was getting ready to go through chemotherapy. And if you know of anybody who's ever been through chemotherapy, it can be really difficult depending on the kind. And that second time I saw him was, I think, the time in which I really realized how much I needed to learn with him about my ability and my comfort in attending to that emotional distress. When I saw him that second time, he came in after that initial diagnosis. He was a lot more despondent, a lot more distressed, a lot weaker. And that was really difficult for me to see him like that, especially because he was a pretty big guy when he first started and he was so matter of fact. And so to see that abrupt change was such a reminder of what cancer does to somebody, but what treatment does. And then as he told me about what he had to go through and not having a bathroom, not having any place safe to rest, it hit in really hard ways that I hadn't actually even considered before, which made me feel bad as a social worker, not thinking about that in advance enough. But again, you can already hear, now I'm thinking about me. I'm thinking about, why am I not enough for this patient? Why can I not take care of him in the way that I need to? And so I had to take a step back and really sit with my own feelings of, you're feeling sad, and that's okay. But we got to focus on Fred. And the only way that that's going to happen is if you focus on your own feelings and let them sit there. And it's okay to feel inadequate. It's okay that you missed that. It's okay that you feel sad.
Yeah, you mentioned, early on in the talk when you're talking about this, that you discovered that here's this patient and he's homeless.
Yeah.
And he's dealing with this cancer diagnosis. In addition to the difficulties of just the treatment and whatever you're going through with that, like you said, those things of that, just you can't even fathom of, how do I get to a bathroom? How do I get to a place to lie down? How do I get just some general peace and quiet to be able to rest, that just, are so above and beyond what you would think somebody going through that would have to deal with. But then to have that layered on top.
Yes.
Yeah, that's just tremendously difficult. And I think that story, also highlights what makes it, that kind of moment, so challenging for helpers, people who are trying to get involved and help. You described wanting to kind of avoid going back to see Fred and realizing that it was not just helplessness, but this feeling of I wasn't enough. Is that a common feeling that people have of I just, and one thing you mentioned was he needs housing. I don't have housing. I can't provide housing. And I thought that was, it was you kind of rationalize these things out where you're well, I don't do this and I don't do that. So, obviously I'm no good to anyone in this situation. Yeah. And that's a common kind of thing that people do.
Yeah. And I think it's both and. So I don't know if you've watched any of The Pit on HBO. I'm sure
I'm familiar with it. Yeah.
Healthcare providers are listening to this. They either are avoiding it for a good reason or they've watched it and they know what I'm talking about. But I think many, if not all, healthcare providers want to do good for their patients, and they want to be what their patients need, and they want to save lives, and they want to improve lives. Even hospice and palliative care, when we're at the end of life, we want that quality of life in that moment to be as best as it can be and aligned with what they want. And sometimes that can't happen for lots of different reasons, way outside of our control. Most of the time, it's way outside of our control. But because we're in those positions of power in a way where we have that relationship with our patient, it's easy to sort of absorb that. I did something wrong. I missed the mark. It's my fault that this didn't happen. I have the control or power to do something, not recognizing that it's way outside of our control and power to do. I talk about The Pit because they, I think, do an excellent job of highlighting the weight of that emotional heaviness and how each clinician sort of handles it a little bit differently. And so that is one part. And so it can present itself in a couple different ways. One way it can present itself is sort of this just, woe is me. We're on ourselves. This is terrible. I'm very sad. But another way we can present is sort of this avoidance limits scope. This is outside of my scope. This is outside of what I can do. I can't do anything about it. And so they just shut off the caring. And so people it's sort of like a curvilinear relationship where some people are sort of at the opposite end and they're, woe is me, taking everything on, really weighing them down, emotional fatigue, compassion fatigue, burnout. Then you have this other side of it that's just disconnected. I'm not connecting with this patient. I'm here for this particular purpose, not anything more than this. Boundaries out the wazoo, just really not allowing themselves to engage at all. And I think that those emotions also result in some of the same crispiness, as we say in healthcare fields, as the folks that are really carrying all the weight. So effectively figuring out how to manage all of that requires that emotional awareness and that ability to empathize in ways with regulation and not letting it jump too far one way or the other. But it's hard.
I think it's interesting too, we're talking about this, and I think a lot of people would probably can connect with this and understand it. But I think a lot of people oftentimes look and think, if they're in that situation, they look at the professionals around them, the doctors, the nurses, all of the clinicians, the social workers, people who are in that system, in that environment, and they jump to that conclusion of, well, you have all the answers. And very clearly, or you know how to handle this. And very clearly, oftentimes, that may be true to some degree, but as you're kind of pointed out, it's not always the case. Like the
Right.
people who are working in this situation often are left with those
Yes.
kind of hanging questions and awkwardness and difficulties as well.
Yeah, and that's frustrating for both people. It's frustrating for the patients and the people going through it because they're looking to someone to make it better. And it's frustrating for the people that are trying to make it better because maybe they can't for different reasons or they don't know how. And specifically regarding communication, it can be difficult because at one point in time, the history of medicine was the provider did know everything. The provider decided everything. There was little involvement from the patient. The patient didn't have to make any decisions because physicians were making all the decisions. And as we've ebbed and flowed, we're on the sort of other end of things where sometimes healthcare providers will display an array of options of treatments. And then you as the patient are expected to pick which one. And you're thinking, I don't know
Right.
what to do here. What would you do here? And so in those moments, clinicians of all kinds, of all disciplines can kind of get caught off guard because then they think, okay, what would I do? But if we can keep the goal being what's most important to the patient, the person in front of us as the guiding light, if that is always anchored and centered, then there is no wrong answer. And so typically responses with questions like that aren't as cognitive as they are emotional. They're looking for reassurance, for guidance, and having the conversation. And so when we're able to lean into it and sort of say, well, what's important to you, and understand what they're experiencing, it does take the pressure off of us. We don't have to have all the answers because they actually have all the answers, and we have the knowledge to help then make recommendations that are aligned with each other. So it really takes both people. So I think this pendulum swing from the left to the right, the truth is always somewhere in the middle. It really takes both people. The healthcare providers don't really have all the answers. The patients certainly don't have all the answers. But if they work together and they're able to sort of lean into each other and trust each other, it's a big part of it, then they can navigate those difficult situations with a lot more curiosity and a lot more compassion. So as long as they take the pressure off of having to know the right thing at the right time.
I thought it was interesting too. One of the things that you were talking about was that, like in Fred's case, and often it is the case where as family members, we think that we're searching for those things to say, those pillow messages to say, the right thing to do, the right thing to say. And oftentimes the patient doesn't really even want any of that. They just want you to be with them through the experience.
Yeah.
And I think that's oftentimes so hard for people to, because in a sense it's a control thing. Like I'm letting go of some element of control of this situation of my life. I don't have the answers that I feel like I should have, when ultimately this person just wants me to just go through like they've acknowledged, like this is where we are, and I'm on a finite time frame here, and nothing's really going to change this. I don't want you to look for solutions to this. I just want you to be in the moment with me and go through this. And that's really hard for people too, isn't it?
Yeah, I think so. And it's hard for people to say that for on the other side of things. So we often think, when I was practicing my TED Talk, I practiced it in front of somebody who had then self-disclosed that they themselves had a serious illness. And I didn't know that before I gave the talk. And so my perspective of this talk has always been how to guide others in communicating with the person who has the illness. But this person actually gave the perspective of the person with the illness and how helpful it actually was for her. And she said, I've got to speak up and say what I need from people. Oftentimes people are eager to say, let me know how I can help. But oftentimes people are like, I don't even know what to tell you to do. And so again, it's that partnership between us offering ideas, offering suggestions. And that doesn't have to stop at just support. Would it be helpful if I got you a glass of water? Would it be helpful if I came over Tuesday night and vacuumed your house? Just offering things that you think might be helpful. And sometimes that language then gives the patient or the person that's going through it the opportunity to say, oh yeah, actually that would be really helpful. Thank you. Or no, I don't need that, but you know what I do need? I need this. And emotions kind of go the same way. if we're talking with someone and they haven't maybe necessarily disclosed anything about how they're feeling, people are afraid to sort of offer an emotional hypothesis of, are you feeling X, Y, Z? Are you feeling scared? Because they don't want to be wrong. But sometimes people need other people to say it out loud for them when they're not able to. And it helps them get to where maybe they are feeling and helps them identify that feeling. Or sometimes you nail it right on the head, and that is exactly how they're feeling. And being able to name that for them was exactly what they needed in that moment. So that process of helping figure out who needs what and when, again, it doesn't all fall to one person. It has to be a mutual exchange. But all of that halts if we don't even attempt to lean in and we exit the room before the conversation even happens.
It reminds me of when people suffer a loss in their family, they've lost a loved one, and after the funeral is over and people come up and they say, if there's anything I can do, just let me know.
Yeah.
If I could, provide meals or anything like that, you just let me know. And it puts everything on that person to have to then come forward and say, as opposed to saying, next Tuesday I'm bringing dinner.
Yes.
And then the following Tuesday I'm going to bring dinner.
Yes.
And then we'll move from there.
Yes.
To be able to give some sort of concrete, definitive, like, this is what I'm going to do. And if you don't want it, let me know. But this is what
Absolutely.
this is the action plan that I'm going to do, as opposed to just saying, well, just some nebulous, let me know what you need, because people can't often or don't know, or they think it's an imposition
exactly
to do that. Here I am in my time of loss, and I don't want to be a burden to other people or whatever.
Right.
But it takes that, and that's you talk about that shift of for your experience of from stepping back to leaning back in, and just being present in the moment, and finding those just simple, just taking a simple step to lay something concrete and tangible out, and then negotiating it from there. Like, if the person doesn't want X, Y, or Z, then they can, you're at least laying the option out in a sense.
And those proposals can come from an informed place if you ask questions to get to know what's going on with that person. So this framework of questioning comes from research done on this serious illness care program out of Harvard, Ariadne Labs. That's sort of where all this comes from. And I'm just taking it and applying it to individual people, regular relationships outside of healthcare. But that's where it starts, it starts by saying, is it okay if we talk about this? Do you want to talk about this? And then as you start to talk about it, asking more questions than you answer, asking questions and then sharing information, and then asking more questions, asking what's important to them, asking what they're hoping for, ask them what they're worried about. And sometimes through those lines of questioning, then they'll give you information that informs what you could offer to help without saying, what do you need? Because sometimes they don't know how to say what they need. They don't even know what they need. But you not being that person going through it, you have the perspective. If you can tap into it, using the information they've given you from the questions you've asked, then say, well, here's what I can do. And if you look at that in a professional client relationship or healthcare professional patient relationship, it's a simple finding out what's most important to them and then offering a recommendation based on that information. And individual relationships aren't really any different. But oftentimes we come from our own place. We skipped past go. We didn't ask the questions. We think about what we would want. And I think that's some form of empathy, but it's typically self-oriented and rooted, and it's missing the most important ingredient, which is the other person's experience. So
I love how that's just applicable to across the board to everyone, healthcare providers, family members, even friends in the community or that particular person's faith community, to not feeling like you have to have all the answers, but just being able to, make an initial kind of entrance into the conversation. If someone's listening and they're thinking of a person in their life that they've pulled away from, what would you recommend? Like just a generic, like, what's a good first step to reconnect that maybe wouldn't feel awkward or forced.
Yeah, well, you know your friend the best, and if you're pulling away from them, then you likely know the reason why you're doing that. And so however you typically communicate with that person, whether it's text, whether it's a call, whether it's a, hey, do you want to go meet up for drinks at happy hour or whatever, initiate that ask of, can we sit down? And that is equivalent to that, can we talk about this? And then when you're in front of that person or you're talking to that person, text or call, then you can say, is it okay if we talk about this? Or are you in the mood to talk about what you've been going through? Or seek some level of permission, because it might not be a good time. And that doesn't mean that it's never a good time, but it means that at that moment, maybe not a good time. But it also lets that person know that you are somebody who wants to know. So even if you are told, I'm doing okay right now, I don't really want to talk about it, they already have received some type of validation from you in just the fact that you asked. And so that would be my advice in that first initial reach out, is however it makes sense to your relationship with that person, and then making sure it's a good time. And then once you've figured that out, maybe it is a good time that they can chat, or maybe you set up a date to go chat. Then you can get into some more of the questions around what is it that they're going through in terms of what are they hoping for? What are they worried about? What do they hope happens, which isn't always the same as sort of what are they hoping for, but what are they hoping happens? What are their goals? There's lots of different kinds of questions you can ask, but as long as they're open-ended and allows them to sort of provide that information, it will give you a lot of context.
And going into it, trying to use questions to open the door to conversation, but without trying to fix anything. You're not trying to come into it with this agenda of like, how can I help you solve this problem?
Right.
My wife often tells me that coming into the conversation, like, I don't need you to fix it. I just need you to listen.
Yes.
And show some empathy. And that sounds really hard what you're going through. What are some examples maybe of some responses, if there is such a thing, that sounds supportive, but doesn't try to cheer someone up or solve the issue?
Yeah. So there's several different phrases. There's an educational program called Vital Talk, and it's a whole comprehensive program with training, and it's designed to help healthcare professionals learn how to communicate with people. And so some of the things that they suggest and some of the sayings I have picked up over time, one of the ones I like the most is, I wish things were different. I feel like any type of statement that allows you to align with that person, where you're both acknowledging that things suck and you wish it were better. The I'm sorry sometimes gets a little old, so that I wish is a different way to also say that I hear you. I don't think that silence gets used enough. Sometimes you don't need to say anything at all and can just sit there and be present. People are generally pretty uncomfortable with silence. And so if you give somebody 15, 20 seconds, they will fill that silence with something. And sometimes if they're searching, that something is something you want to hear. So I would often just not respond at all and just sit there and allow them the space to talk about whatever they need to talk about. And it's also okay to ask, do you want me to help you think of solutions, or do you want me to just listen? And they can tell you. Sometimes I do actually want some help with problem solving. And if that's the case, great. But if they don't, they might be able to say, I don't really want you to try to fix it, or you can't fix it. There's nothing to fix.
I think it's a good idea to kind of prep on these things and really think on this for whenever you might go through this experience, because I feel like those things that we tend to do, the I'm sorry's or whatever, are just fallback kind of, it's kind of a learned behavior kind of fallback kind of thing. Yeah. And if you practice these other things, those become the fallbacks, and they're much better options. And I agree, the learning to take a moment and be silent, you know, I think you can probably, it's such a weird, I'm pulling from such a weird area, but I've seen so many people over the past several years who've talked about negotiating for buying a car. And when you go in to sit down with the finance person and they bring this stuff up, and you just sit in silence and wait for them to
Yeah.
then maybe change the terms of the offer a little bit because they detect this weird, because most people aren't
That's
comfortable
right.
with
Yes,
that.
exactly.
And I think it applies to so many different situations where if
Yes.
you just give it a beat. Interviews are the same thing. We do interview training for people.
Okay.
And a lot of times we will talk to them about the fact that, like, a lot of times reporters or people who are doing an interview will ask a question, you'll give an answer, and they'll just kind of sit in silence. And maybe they've got a notepad and they're just kind of writing in their notepad, and they'll just let you sit. And oftentimes people feel uncomfortable enough that they will feel compelled to blurt out something to fill that void.
Yes.
And that's part of that training, is to be like, don't feel like you have to do that.
Yeah.
Like, they're interviewing you, wait on that question. They'll ask the next question. You don't have to do that.
That's so true.
So, yeah.
I know I feel bad because nothing that I'm saying, I mean, all the principles, the frameworks, the strategies, the tools, everything that I use is out there. It's all been developed. It's been studied. I just take it and put it all together and kind of package it in the same spot and try to apply it to areas where maybe people haven't thought about applying it to. So I feel like I'm cheating a little bit in the sense that people way smarter than me have done all the hard work. And then I'm just using all of that work and trying to use it in a way that will help in the most like normal way.
Sure. But I also too think that, like, you mentioned the conversation guide.
Yeah.
To help clinicians ask better questions, but the importance of that for everybody, and that idea that prompts help not because they're scripted prompts, but because they make space for compassion.
Yes. Yeah. We often think, so I did a study a while back where I interviewed a lot of nurses, and it was about their approach to taking care of individuals who are unhoused. And most of what they talked about was action oriented, right? And nurses are natural helpers. They're go-getters. They're going to be the first ones there in line to do something. And so that makes perfect sense. And they would often talk about what they can do for them. And after the third or fourth interview, I suggested, what do you think about just listening to their stories or just being present and compassionate? And they're like, yeah. But I mean, like, what am I going to do? And so it's this idea that sometimes that's enough. Mm-hmm. Sometimes that's okay. And sometimes that's all there is that you can do. Because in my experience with Fred, I didn't have any of these actual tangible items to help him. And it's easy to use that as an excuse to disengage. And I heard that in some of the interviews that I held with some of these helping profession-oriented folks, and their desire to back out of that room as quickly as possible because they felt a little bit helpless and a little bit distressed.
We, these are conversations that are not only about illness, but they're about grief in many forms. And as a society, as a culture, we struggle with grief quite a bit. But I think about our shifting demographics and how the need for this is increasing. It's not decreasing. Like the need for people in hospice care and palliative care, the need for us to maybe be a little bit better equipped because we have such an aging population.
Yeah.
And like we said at the beginning, like, social workers are everywhere, but we have such a need for more social workers. So yeah, I just, there's so much that this touches on, because of that.
Yeah. Well, that was sort of some of the impetus behind starting this elective 580 in the fall, was around, even if you're not going to go into the specialty of palliative and hospice care, you're going to interact with somebody who has a serious illness at some point in your life. And if you're in the social work profession, you're likely going to interact with them often. Even if you're in the child welfare system, there's a lot of kinship care, which are often older adults taking care of young children. And those older adults are getting older and they're getting sick. So understanding what that older adult is going through. But young people get sick too. And so helping them understand what's going on. So even if you're not somebody who is going to be in that specialty of palliative and hospice care, this course and what I hope to do in my career is really support individuals who aren't specially trained, actually really support the folks that could just use the skills. to have these conversations when they need to. And they might not have them every day, but goodness, wouldn't it be helpful if we had something to sort of fall back on with some basic knowledge of, I remember. Oh, yeah, I remember this being a thing. I remember what to do here, and not feeling so caught off guard, and hopefully maybe have had some time to examine and know thyself a little bit before that experience happens. So if people can walk away with that, then I feel like I'm doing a good job, but that's what I'm hoping to do.
This has been such a rich conversation. I'm very grateful for the chance we've had to talk about this. If someone's listening to this and they want to know more about this conversation guide, they want to know more about being able to find the answers or find the path to be able to do this well, are there some places that you can recommend that people maybe start and go find to search to get some more information?
Well, always email me. You can always email me. I have my staff directory up on the College of Social Work's website, but there is an emotional PPE website that's really, really good and can help folks, especially in the healthcare profession, who are dealing with a lot of those sensitivities and helping attend to some of the distress that comes along with that. That came out during the COVID pandemic, and it still is available to folks. They can tap into that.
Is there something specific they search for to find that?
I think you can just Google emotional PPE and it will come up. It's like a project. There's also the Center to Advance Palliative Care, CAPC. The University of Kentucky is actually a member of that organization. And so as a member, you can log in for free and have access. And it offers a lot of training, anticipatory grief training, palliative skills training, hospice training. So if you're somebody that just even wants to know sort of the 101s, that's a great place to go to as well. And you have access to that if you're, have a uky.edu email.
Excellent. What's in the future for you, for this talk and for the work that you're doing?
So I have a couple of projects going on. I'm adapting and helping some heart failure providers at a clinic implement the program in their clinic, and then hopefully going to expand that. And I'm also helping a homeless shelter in Louisville take this program and put it into their system. And it's proving to be really challenging, but really rewarding. And just more of that, I think, helping folks. And then this class that's going to start in the fall, and then hopefully in the spring, then we'll offer the sort of second part to that class and have an advanced psychotherapeutic-oriented class as an elective. So just a couple of things.
Just a few. Just a few. That sounds great. Excellent. Abbie Latimer, thank you so much for taking the time to talk. I really appreciate it. It's been a great conversation.
So yeah, absolutely.
Thanks for listening to Behind the Blue. Behind the Blue is a production of the University of Kentucky. For more stories about how the University of Kentucky is advancing our Commonwealth, visit uknow.uky.edu.